I am so excited to introduce our next speaker, who is Marie McCarthy. Dr. McCarthy is an assistant professor of epidemiology in the Department of Biostats, Epidemiology, and Informatics. Her research goal is to reduce the burden of cancer through improved prevention and screening strategies, particularly for ethnic minorities. Her work seeks to integrate genomics into clinical care and to develop tailored prevention strategies based on individual patient risk. I'm so excited to hear about your research.
Wonderful.
Welcome.
Well, thanks so much, Sarah, for that introduction, and thanks to the GGHE for supporting some of this work that I'm going to talk about today. And so I'm going to give a little bit of a background on breast cancer disparities, talking about precision screening and racial disparities, and then highlight some of our preliminary findings from our GGHE funded work, some new, very new data that we just generated, and then talk through some of our next steps moving forward. And so unfortunately, there's large and persistent racial disparities in breast cancer mortality in the States. This figure shows the number of additional deaths among Black women compared to white women for women with breast cancer. So among 100 breast cancer cases in Pennsylvania, there were 3 to 8 more deaths for Black women compared to white women per 100. And you can see that there's some variability across geography with higher levels, higher disparity in breast cancer mortality in some of the southern states, but also, there's some geographic variability. And so this is a very important and concerning disparity, one that I'm very interested in trying to understand and ameliorate. And part of the reason for the difference in mortality, similar to other cancers, is the fact that Black women tend to be diagnosed at a later stage of breast cancer than white women. So here we see the proportion of Black versus white women diagnosed at localized resistant stage. And you see that Black women are less likely to be diagnosed at an early stage and more likely to be diagnosed at a later stage when the disease is harder to treat, harder to cure. And so it's clear, given that we're seeing these large differences in stage of diagnosis, that early detection is going to be a key tool to help us reduce disparities in breast cancer mortality, Black and white. And so for a long time, we've just been thinking about screening recommendations as a one-size-fits-all approach. So based on age and maybe family history, we tell women whether and when to start screening. In the US, the last guidelines from the U.S. Preventive Services Task Force recommended screening beginning at age 50 every other year. And they said that in women in their 40s, it should be a personalized decision as to when to start, whether or not to start screening. There really wasn't any guidance given in terms of what risk information you might use to make that. And I think that we're getting to a point where we actually do know a lot about breast cancer risk. We do have improving breast cancer risk prediction models that might be able to help women make the decision. When should you start screening? Should you start at 40 or 50? Should you start in the middle? Are you at very high risk and you can consider screening even earlier than 40? And then how often should you get screened? Is every other year really okay? Or should I screen every year? And then in terms of how should I be screened, should I just be screened with mammography, or should I consider supplemental screening with breast ultrasound and breast MRI? So these are the questions that need to be answered, and I think we need a better data-driven approach to guide these decisions. And so I'm going to talk a lot in this talk about one particular risk factor for breast cancer, which is breast density. So breast density is the relative amount of fibroglandular tissue versus fat tissue in the breast. So here we have 4 different mammograms with 4 different levels of breast density. On the left here, we have the least dense, and here we have dense. So you can see here, there's a lot of dark tissue. There's a little bit of white tissue there, but you can kind of see most of the breast, whereas when you get into these two, you see a lot of dense fibroglandular tissue. And so when patients have increasing density, the risk of cancer developing is increased. So women in the highest level of density have 4 times the risk of developing breast cancer compared to women in the lowest density level. And part of that is because it's fibroglandular tissue that gives rise to breast cancers, right? So obviously, if you have more dense tissue, you have more tissue prone to developing cancer, higher risk. But the other interesting thing about breast density is that increasing breast density also reduces the performance of screening mammography. So because you have all of this dense tissue, it can be hard for the radiologist to actually. And I'm not a radiologist, but I can kind of tell that this kind of looks weird. This kind of looks weird. This is a tumor. Apparently there's tumors here and here in these breast images as well, but they were not able to be detected on the mammogram by the radiologist. And so breast density, so for this lowest category of breast density, mammography sensitivity is 88%. So 88% of cancers will be detected on a mammogram among women with the least dense breasts. Whereas sensitivity is only 63% for women in the highest breast density category. So false negatives occur where patients get a mammogram, it's read as negative, but women end up having the cancer missed or developing the cancer shortly after screening. And so based on this, there's been some discussion about whether mammography is sufficient for women with dense breasts. And so about a few years ago now, there was a very large trial that was done in Europe, the DENSE trial, and this randomized women with dense breasts, the highest category, extremely dense breasts, to receive MRI or not, and then followed women to see outcomes. And what they found is that breast MRI significantly improved cancer detection. It reduced the interval cancer rate among women with extremely dense breasts by 50%. And so we saw a higher cancer detection rate of 16.5 per thousand. The false positive rate was 8%, which is a little bit on the high side, but actually not as high as we may have expected. And we found that these cancers that were detected on MRI were mostly invasive cancers. So one concern about using MRI is, are you just going to detect a lot of DCIS that may or may not be clinically relevant to patients? And that's not really what we're seeing. We're seeing that MRI increases the detection of invasive breast cancers. There's also an observational study in BRCA1 and 2 carriers. So BRCA1 and 2 carriers, as you know, have very high lifetime risk of breast cancer, and they're recommended to undergo MRI screening every year. And so they did a trial where women were screened with breast MRI, breast ultrasound, and mammography all within a short time window. Those screening tests were read independently, and then it was evaluated which method was best at detecting cancer and which types of cancer. And it was found that MRI was detecting tumors that were not visible on mammography, and it wasn't just DCIS. So this evidence suggests that MRI can improve cancer detection. And so there's been growing interest in expanding MRI screening to women with dense breasts. And this has really been driven by advocacy organizations. So breast cancer advocates are very successful in advocating for and getting passage of legislation on the state level to require insurance coverage of supplemental screening with breast MR and breast ultrasound. In Pennsylvania last year, there were 2 laws passed in the last 3 years. The first required insurance coverage. The second required insurance coverage without copays for MRI screening for women with extremely dense breasts. So this is growing, and I think the data is just starting to catch up. The DENSE trial reported out. They had a 2-year follow-up that reported out that showed good findings. And so this is the idea of personalized screening, where not only are we modifying when you start and how often you screen, but also how you screen. That's really expanding. Okay, so how does this affect racial differences? So as I mentioned, breast density is a strong risk factor for breast cancer. It's a strong risk factor for breast cancer in both white and Black women. However, when we look at the typical 4 categories of breast density, we see that Black women have much lower breast density on average than white women. And so breast density, these 4 categories, these are categorized by the radiogram. And so there's a level of subjectivity there. And there is, if you look back on the pictures I showed you, the radiologist is looking at how much dense tissue there is in the breast. But it's really a relative measure when you're subjectively looking. And so what we see is that we really think that this is driven, the differences in the racial differences in density appear to be at least partly driven by BMI and larger breast size and more fat tissue in the breast. So in our studies, which I'll show you in a minute, we actually quantified breast density levels using computer vision techniques and algorithms. And so I work with Despina Kantos, who developed this technology, and her lab, where they actually use computer science to do a quantitative measurement of the amount of dense and non-dense tissue in the breast. And so we did a study looking at racial differences in breast density when we use these quantitative measures. And so this is comparing measurement of breast density with BI-RADS, which is the visual radiologist. And then we looked at two different measures, the area percent density and the volumetric percent density. And we found that when we looked at BI-RADS density and when we adjusted for BI, we saw no difference in BI-RADS density. But interestingly, when we used the quantitative measures and we adjusted for all of these factors, we found that Black women actually had a higher amount of dense tissue in the breasts, right? So this is an example of a breast cancer risk factor that is strongly associated with breast cancer, but what that risk factor means differs between populations. And this is something that we really are interested in taking into account when we do breast cancer risk prediction modeling. And so this is just a small case control study here, looking at how the quantitative measures of breast density predicted risk among Black and white women. And so we see these are the odds ratios for area percent density and volume percent density. So this is the older version 2D mammograms. These are the newer 3D mammograms. So most of our work moving forward is good. And we find comparing the odds ratio for breast density in white and Black women, they're similar, highly significant. And we also see that the area under the curve, or the predictive accuracy of breast density alone, is actually pretty high. And so based on this data, we submitted 2 grants and got funded by the American Cancer Society to further investigate these quantitative breast density measures with respect to breast cancer risk, and also to layer on polygenic risk scores to see if we can put together volumetric breast density with polygenic risk, how much can we improve risk prediction for Black and white women. And so to summarize the background, large persistent racial disparities in breast cancer mortality. Breast density is a strong risk factor for breast density, but Black women tend to have lower breast density when the subjective BI-RADS measure is used. We have used our quantitative measures that have shown Black women actually have more dense tissue than white women on average. And we're thinking that we can utilize this information, leverage this information to improve how we are able to do risk assessment. Interestingly, there's not a lot known about the biological underpinnings of breast density and risk. We do know that from studies primarily in European populations that breast density is highly heritable. About 50 to 70% of the variance in density is explained by genetics. At the time we started the study, there were 50 genetic loci that had been previously identified. However, all of those studies were in European populations. There were none, or a few in Asian ancestry populations as well, but none in African ancestry populations. And another limitation or thing to note about prior studies is it was really focusing on the 2D mammograms. And so the GGHE pilot that we were funded for is a collaboration with Shefali Verma, who's here, and Despina Kantos. And the first aim is to perform a genome-wide association study of volumetric breast density in Black women. And then the second aim is to develop a polygenic risk score for volumetric breast density and to look at whether that risk score is associated with breast cancer in Black women. And so we did a preliminary study with the data that we had in hand. What we're doing is we're linking the mammography screening cohort that we've developed with the Penn Medicine Biobank. So we have data on all women who have gotten mammography in Penn Medicine going back to 2009. We've pulled those images, we've linked them to the cancer registry for outcomes. And so we've got this very large and diverse cohort. We started with the data that we had in hand, the earlier data, the 2D mammography data. And we limited to patients who had genotypes available from PMBP. We excluded BRCA1 and 2 carriers, patients with a prior breast cancer diagnosis, patients with breast implants, because that makes the density algorithm a little bit hard to interpret. We excluded some patients whose images were unavailable or could not be measured. And this work was published in 2023. This is the characteristics of our study population. This is among women who self-identify as Black or African American. We had 1,300 patients at the time who had genetic data. We ran our quantitative measures and also looked at covariates, including body mass index. Again, the BI-RADS category of density shows a small proportion of Black women with extremely dense or heterogeneous dense breasts. And about 12% of patients had family history, and this was a small study, so we only had a few breast cancer cases in the study. But so we're really focusing on the outcome of density. And so when we ran our GWAS, we found 65 significant hits, consisting of 29 independent loci. There were 9 SNPs. So most of the SNPs were associated with dense area. Some were also associated with the percent density. So that's about whether we're looking at the dense tissue versus the percent of the breast. So it's different metrics. Yep.
So I assume you controlled for BMI
We did.
analysis.
We did.
I would think that's strongly correlated. And also any substructure.
We did. We adjusted for components of ancestry.
Because that's a lot for a pretty small number, actually.
It is, and we were curious about why that might be. We thought that, part of it could be that it is a highly heritable condition. So therefore we have potentially more power to detect the difference. It's a continuous variable. So we were running this as breast, rather than using the categories, we're using breast density as a continuous measure. So that's another part, or, it's a small sample, so we can't rule out the fact that some of these results might be spurious. But Shefali, do you want to talk more about any of the?
Yeah, I think that we were definitely concerned. These are just the 29 loci are only based on the LD structure in the African population in our data set too. So we did find mapping, not everything fine map. There were only a few that fine map. So we did do tons of post GWAS stuff here to understand what may be useful. We don't have another data set to replicate these findings. Something to note here is we're showing 3 GWASs here, but most of it just come from the dense area GWAS, but not from others. So they do only replicate in dense area. That's one of the things to notice. Yeah.
Yeah, and I can show you more to kind of get to the point of could any of these be biologically plausible? So we looked at the results that we found and how they stacked up with previous both breast cancer and breast density GWAS. And so of the loci that we considered, we found that many of those had already been identified as having low significance. We found some overlap between the loci that we identified in this African ancestry population with the European ancestry populations. That's about 57 loci overlapped with what was seen in breast density loci in European populations. We also found some overlap with loci that had been previously associated with breast cancer. So we found 13 that were identified in European, and then 3 loci that had been previously identified as associated with breast cancer among African ancestry women. We also looked at some of the biological plausibility of some of the highest, strongest associated SNPs, and we find some alpha catenins as associated. And for example, this catenin alpha 3 came out in previous breast cancer GWAS. It's been associated with cancer cell metastasis and, interestingly, metabolic syndrome in African ancestry populations. The metabolic syndrome connection is interesting, given that we seem to see differences in density by obesity levels. Catenin alpha 1 was associated with both breast cancer and a hereditary syndrome for gastric cancer. HSD 17B6 associated with androgen metabolism, PCOS. Also, another SNP associated with metabolic syndrome or metabolic phenotypes, and then GACAT3 associated with gastric cancer, and also has been shown to be expressed in breast cancer tissue and associated with breast cancer prognosis. Yep.
Question. Were those two CT and N genes totally independent? Are they near each other? Or is it just like totally independent association?
Yeah, that's a good question. Do you remember, Shefali?
These are different loci, but I don't remember them.
Because it just makes it more intriguing. Like if they are really totally independent, then that's that's interesting that the same type of gene is coming out.
Yeah, we can look into it more, but I don't remember that.
Yeah, that's a good point. We also did some fine mapping, and again, looked at genes that came out as mapping with both dense area and percent density. Again, we're seeing heterochromatin genes, some of these have some biologic plausibility as being previously associated with cancer, though not necessarily breast cancer. And then we did a PHWAS looking for traits associated with at least two genes, and we found, again, cardiovascular traits, lipid measurement, immune system, BMI, response to drugs. And again, we recognize that this is all very very exploratory, very hypothesis generating. But we also, when we did the GWAS catalog update, we found some that were also associated with breast size, which makes sense, bone density, which has a strong estrogen related component. So and sex hormone binding globulin. So we recognize that this is really small. This is only, but even in this small set, we got some results that are interesting for further follow-up and might have some biologic plausibility in terms of helping us understand the connection of the biological underpinnings of breast density, really, in women of African ancestry. And this was really the first study out there looking at SNPs for density among African ancestry populations. And so we're going to repeat this. I'll show you our new data set, more than double the amount of Black women. So we hope to repeat these GWAS findings to see if they validate in the larger sample. I'm going to change gears a little bit now and talk about breast cancer polygenic risk scores, because, as I mentioned, that's another key risk factor that we want to layer on to see how much the combination of the two can improve risk assessment. And so in breast cancer, there's a well-validated 313 SNP breast cancer polygenic risk score. It was developed by the BCAC consortium. It used almost 100,000 cases and controls. However, they were all European ancestry patients. The BCAS study then integrated risk factors together with the PRS model in another very large study. And they found that adding polygenic risk scores to classical risk factors significantly improved risk assessment. So here we're seeing the AUC, so the predictive accuracy of risk factors alone, risk factors plus PRS, and risk factors plus PRS with an age adjustment. And so we see that when we we're getting here into a realm of AUC that's actually getting more clinically useful. So one of the big limitations of breast cancer risk prediction models to date is that they're just not that accurate. So their AUC is about 0.6 when we non-genetic risk factors. And so here we're starting to get into the realm of predictive accuracy that's similar to what we see in cardiovascular disease, for example, where risk assessments can actually be more meaningfully applied clinically. However, one important point to note is that these do not include breast density, which we know to be a strong risk factor for breast cancer. So we think that there's still room to improve on this AUC by combining breast density in addition to clinical and genetic risk factors. And then this is data that just recently came out this month, a very large study, polygenic risk scores in a large screening cohort, I think in Finland. And this shows by the different colors are different outcomes. So this is showing among women who didn't get cancer, what proportion of women, what are the proportion of women that didn't get cancer in each of these deciles. So basically, when we get above this 10% threshold, it's showing that these patients there's an enrichment for the trait among these higher deciles of PRS. And so we see that both in situ invasive cancer and bilateral breast cancer are much more common among patients at higher levels of the PRS. And here we just see it plotted a different way. And this is very interesting compared to pathogenic variants. So monogenic gene mutations, so things like CHEK2, PALB2, et cetera. And this is family history. So this is the proportion of patients that, let me just double check. So this purple here is breast cancer. This is saying that among patients with breast cancer, 35% of them had a PRS in the top decile, right? And that actually looks even stronger than what we see when we look at pathogenic variants and family history. So this is showing us that in an actual clinical impact of using polygenic risk scores to think about screening outcomes and screening practices. There's also been modeling studies done by the cancer, I'm going to mess up, I always forget this acronym, the group. And so they looked at what would be the effect if polygenic risk scores were used to guide screening. And they found that there were actually several methods to tailor screening that used PRS that were shown to improve life years gained while maintaining a reasonable false positive rate. So there's more and more accumulating evidence that polygenic risk scores might have clinical applicability. The problem, again, is that these polygenic risk scores were developed among populations. This slide compares the findings in terms of odds ratio and AUC for the 313 SNP PRS. This was in the validation set and the prospective external validation set. So we're seeing for overall breast cancer AUC about 0.63. However, when we use that same PRS among African ancestry populations, it's only about 0.57. So this is probably not surprising to all of you who do this type of work, but still shows that we need to do better. So the PRS was predictive, was associated with risk, but not to the extent it was in European populations. There's been several studies coming out. I know this is a very active area of research across disease sites, but there was a study that came out that proposed a way to improve polygenic risk scores for African ancestry populations by Gall et al. And so they did a multi-step process to do this. They first basically re-estimated the associations between individual SNPs and breast cancer risk among the African ancestry population. And then they created a joint PRS that was a linear combination of the African ancestry PRS that was new and the validated European ancestry PRS. And then they also did a hybrid approach for the ER positive, ER negative. So breast cancers express, there's the estrogen receptor and progesterone receptor are expressed on breast tumors. They are, it's a main way of classifying breast cancer, and they are associated both with prognosis, and then they also guide what treatment you get. So cancers that are ER/PR positive, they respond to hormonal therapies, whereas ER/PR negative disease does not. And so there's accumulating data that there's different risk factors for ER positive versus ER negative, and different SNPs associate with ER positive and ER negative. And so I didn't stress that in the previous slide, but the 313 SNP has an overall PRS plus a PRS for ER positive and a PRS for ER negative. And so they did this this kind of weighted approach to combine the ER positive and negative findings. And so they found when they used the joint PRS or the hybrid PRS, they got better predictability among African ancestry populations, although you'll still see it's not that great. So we really need a lot more work in order to improve our ability to identify genetic risk for breast cancer among African ancestry populations. And that's an area that we're really interested here. We think we can lead based on the biobank having so many participants. So we're really excited to help move this field forward. So where are we now? So, yep.
I don't know if they
So,
know the AI.
so this is the ER positive. So interestingly, they get for ER positive, they do slightly better than overall when they use the ER positive PRS. For ER negative, they do better when they do the hybrid versus either the European or the African ancestry, but still not optimal. So ER negative disease is rarer. There's only about 8 to 12% of all breast cancers. So your sample size is much reduced to be able to do discovery. So there's just not as much, and there's not as many SNPs identified specifically associated with ER negative.
So talking about tumor genomics, so
Oh.
ER and then the HER2, right?
Yes.
HER2. So HER2 is also equally important.
It is, and we really haven't included anything classes again because of size, and many of this was actually HER2 was only started being reported to cancer registries, I think in 2010. So a lot of these studies, it's been hard to accrue the numbers and get the HER2 data in. But that's another clear area that we need to go, and I think an area that will help improve our risk assessments if we can think about HER2 as well. And so this is just highlighting that there's a lot more work that needs to be done, and I'm really interested in exploring different options to do multi-ancestry PRS and make it feasible in our clinical populations. Okay, so where are we now? So I showed you our very preliminary data that had 1,300. This is patients who had a mammogram in our cohort and who currently have a DNA sample for analysis in the PMBB. So we've got a total of 7,000 patients, about just over 3,000 African ancestry and over 3,000 European ancestry. Our breast cancer cases overall, we have 400, 150 among African ancestry and 263 in European. And here you can see when we go by subtypes, the data gets pretty small. So this just kind of highlights the difficulty in doing this type of work, which I think is really important, but is also, we need to do this in a multi-center study. And so we're working on how we might do that. So we ran our, we just used right now the European ancestry polygenic risk score in this data, adjusted for age, BMI, and principal components of ancestry. And so these are, our very preliminary BRS findings. So all of these printed, but we're really focusing on the blue line here. So this is the model that just has our just age, BMI, and race ethnicity. And we have an AUC of about 0.65. Here we're just looking at the PRS, no covariates, and our predictive accuracy is 0.62. This is a step that I think a lot of people ignore, like in the clinical realm. How much does PRS add? How much does PRS add? But I actually think it's when we get to, this is only a few risk factors, but when we're doing actual clinical breast cancer risk assessment, it's a lot of risk factors. It's hard to get the data. It's hard to analyze the data for a primary care provider. So I actually think the fact that the AUC is 0.62 for PRS alone, that's important. Because if we do get to a point in the future where PRS measurement is integrated in the clinic, maybe we just go with this PRS score alone. Maybe we don't have to bother with what is their family history? What is your reproductive history? Have you had any biopsies? Because all of that takes time. So I think that's something I really wanted to note. And then when we put them both together, we do get an increase in AUC 0.69. So a little bit better, but not.
I have a question.
Yep.
Did you say it's better than doing family history, or did I miss?
Well, I'm just saying that it's if we can get an AUC of 0.62 with just one measure that doesn't change over a lifetime, it's a lot easier, right? So I don't want to. I feel like we always jump to the like, oh, this didn't really. But if we get to a point where we integrate it, and you're just this, a doctor can look at a score and know you're high, moderate, or low in terms of PRS, and that never changes. We can whenever you go in to get a mammogram at Penn, you fill out this risk factor questionnaire. It's very extensive. The Gale score is calculated. It all sits in Epic Radiant. Nobody looks at it. Primary care providers cannot physically see that information because it's in another part of Epic. We're doing nothing with that information. So breast cancer risk assessment is really not being done. Maybe it's being done if you ask. Maybe it's being done by certain primary care providers. Maybe it's being done if you have a family history and you go to genetic counseling. But by and large, we're just not doing this because primary care providers don't have time. We don't know what to do with the information. The risk models aren't that accurate. So there's a lot of limitations to doing, the risk factor approach. And so I'm just making the point that we have to keep that in context when we think about what the AUC is for PRS alone. Because I actually think like providers it's probably easier for a provider to just get a number and know it's high, right? Like is your cholesterol high? We'll put you on. Is your PRS high? We'll get you screened every year, right?
But well, for one thing, then it requires that everybody has to have genotype.
Right. No, I know, but this is looking into the future.
Yeah, I don't know, it makes me nervous because I would just think that like a family history for certain types of cancer would be such an important predictor.
Yeah, no, I'm not saying we should ditch
Gone.
it. I'm not saying we should ditch it. I'm just saying that PRS on its own can do similarly well as.
Unless they're of diverse ancestries, as you were saying.
Right. Right.
That's my concern also,
Right.
that we're not giving the right information to many people.
Right. We definitely need to further account for that. And that's part of where we want to go, because we actually think that adding PRS and adding quantitative density might really help improve prediction, particularly for Black women, because the existing models don't necessarily do as well.
And do you think that because you're looking at genetic variants associated with breast density, is that going to help at all with these PRS, or would it just as well, do the mammogram and see how dense the breasts are, and then you'll know? I mean,
Yeah, well, I mean, I think the issue is you don't know what your breast density is.
oh,
And so if you're a person whose primary care provider tells you don't come until you're 50,
I see.
you're not going to know that your density is high. So given that it's not only about detection with the density association, it's also about underlying that actually knowing it might be useful when we get to a point where, we have everybody has genetic information to the extent that we want, we might have a sense where we look at what's your risk for breast cancer and what's your density level, because then maybe you go right to MRI in addition to mammography, or maybe if the data allows it in a few years, maybe we see for some patients for some length of time, it's just MRI that's needed. So I think that there is value to knowing what your what your genetic predisposition to density is beyond just screening. But great point. Okay, this is, going to look similar to what we've seen before, but our AUC for covariates only among Black women, for PRS only Black women, it's 0.59, and putting both together, 0.74. Again, the number of cases is pretty small. It's about 150. And then this shows our data for breast cancer subtypes. So this is for all breast cancer, 0.74. For ER positive, 0.73, and about the same for ER negative. But again, the numbers and subtypes are very small. So we're really working really hard to expand this data set. We've been working with the Penn Biobank to track recruitment of our patients that we've already identified who have mammograms at Penn and have developed breast cancer. We have about, I would say about 450, 500 Black women that we've identified in our cohort that have genetic information. So we're working really hard to get patients consented to the biobank so that we can include them. We're going to pivot now to expanding our GWAS. We're waiting for the volumetric breast density measurements to completed. They're being run currently, and then we'll be able to do our larger GWAS, repeat the density GWAS in those patients, and then think about looking at polygenic risk score. And then, we really need to dig into various methods to improve the PRS for Black women, whether it's methodology or whether it needs to wait for more data in terms of discovery. I think those are kind of ongoing at the same time. Just in terms of other extensions, we are the grant that I have from ACS, once we have this data expanded, we're expanding even more broadly. We'll be able to look more at the factors that explain differences in breast density between Black and white women. So we know that it's partly about BMI. We're also going to layer on other reproductive risk factors, other biological risk factors, other patient characteristics to really be able to pinpoint, is it just about BMI, or are there other factors that are leading to differences in density, Black and white? And then we can also layer on the genetic findings. So we can look at our SNPs and see, are there genetic differences that partly underlie the differences in density that we see? We're also expanding our imaging biomarkers. So this an example of our radiomics markers that Dr. Cantos's lab has developed. So going a step beyond density, the actual pattern of the breast. This data is a little bit out of date now with AI. So the set of things that can be pulled out to just, deep learning and AI-based models. And I think it's really interesting to think about combining the imaging with the genetics in a deep learning, letting the models determine what combination of factors are most predictive. I'm also doing a study right now to increase the utilization of MRI screening among patients with extremely dense breasts. So we're doing nudges to patients and providers for patients with breasts to tell them that they can consider supplemental screening. And I think that we could use that similar machinery as the data matures in terms of polygenic risk scores to think about how do we help patients and providers tailor screening to individual risk. All right, so I'd like to thank all my collaborators, Despina, Shivali, Marilyn, all of the people that have helped with all aspects of this project, and particularly the GGT who supported some of this work. And I think that the support of the GGT was really instrumental in taking some of this, using it as preliminary data that was then enabled us to be funded for a larger scale study by the American Cancer Society.
Thank you. I've already asked a lot of questions. Is there anybody else who has a question?
No, I mean, you go ahead.
Oh, okay, I was wondering, I don't know if I missed this, but I know that there have been some forms of imaging that they've shown to be less accurate with people with darker skin. So I was wondering, when you were like looking at the mammograms, and you were quantifying that, did you account for that, or is that something that you considered accounting for?
Yeah, that's a really good question. There has been quite a bit of research looking at like the sensitivity and specificity of mammography screening in Black and white women. We don't see large differences when we account for other things like breast density. The question of within patients with dense breasts, if there's a difference in how well mammography works between Black women is really interesting, particularly because of the differences in breast cancer subtypes between populations. And so Black women are more likely to get triple negative breast cancer, which is cancer that doesn't express ER, PR, or HER2. And there's actually some data that those tumors are less likely to be detected on a mammogram. And we're not sure to what extent it's that those triple negative tumors typically have features that look more ER positive. So like radiologists are used to seeing a certain thing in a ER positive tumor that is not what the ER negative looks like. And so it's unclear if they're being missed by the radiologist because they look different, they look more benign, or if they're just more aggressively growing and they're developing with. So that's something that needs to be teased apart, but it's a really good question in terms of, within density, is there differences in mammography sensitivity for Black and white women?
Yeah, thank you. Great talk again. So a couple of questions. The first one is some of the steps that you identified on the GWAS and the link with gastric cancer as well. I had a special, and gastric cancer is common in Asia, East Europe, and South America. So not in Africa.
Yeah.
So I was thinking if there has been studies linking those SNPs with the other ethnic groups as well. So if
I don't know, that finding, the hereditary gastric syndrome gene, that's a pretty new finding. I didn't see anything else, but I should look into it further.
I thought gastric cancer was also caused by H. pylori often,
That's-
right? And that it's
Yeah.
not like there are other non-genetic
yes,
risk factors in those regions.
yes, but I mean those regions are called to be very high risk for gastric. And the second one is breast density and as you age.
Yes.
Yeah, any comment on that one?
Yeah, so breast density does tend to decrease over time, particularly after menopause. So women who undergo menopause, the breast density levels tend to decline. However, we still see that, if you're on the high end of the spectrum of breast density for menopause, you tend to stay higher post-menopause. So breast density, there's been studies looking at breast density and risk, and the risk increase persists up to 20 years after the measurement of breast density. So that is part of the line of research that it's actually about risk and not all about detection, because then you would just see the association in the short term, but we do see longer term prediction of risk. And there's also been some studies, we had a study looking at changes in density. We really didn't see, our study was not that long-term. There's been some longer-term studies, but we see some improvement if you add longitudinal measures of density, but it's not stark. So we think that a one-time measure can be sufficient. We might get a little bit of improvement if we update that over time.
The last one is, I know we also do mammography for male breast cancer, and your focus. So
It is.
comment in terms of control for male breast cancer and mammography and breast cancer.
Yeah, it's a good point. My understanding is that there's not a whole lot of data to support or there needs to be more data on the effectiveness of mammography screening in male BRCA. For example, I was just talking to a clinician who wanted to run a trial of mammography in BRCA carriers. So I think it's an area that definitely needs more research. That's kind of outside of what we're doing. The numbers are obviously much smaller, so it's more difficult to do that work. But I don't know. I haven't seen any studies on density among men, but it's a really interesting question. We might be able to look, we could find men who've had our cohort. We typically exclude them for our analysis, but we could identify those patients and identify the images, and we could look potentially. Yes.
Questions?
I wanted to find out from your GWAS, the X chromosome is excluded, right?
Yes.
So future studies, are you guys planning to also include it?
We just didn't have the data at the time, and the imputed data was, so yeah.
Oh, okay. And then my follow-up question was, since you, like the heritability, like the broad sense heritability is 50%, did you calculate what your SNP-based heritability from your three?
Sorry, I'm answering for you because
No,
I know you're looking at me. We did a stratified heritability estimation. It's in the paper. I don't remember what those look like because of our broad, just overall heritability estimations were not as good. So we did like partitioned heritability estimates based on some of the information we had about the variants. Yeah.
Oh, okay. And then I wanted to find out what percentage of the like SNPs from the actual findings, like from the breast density and then the percentage, like what percentage was left after fine mapping? For example, the ones that had like one SNP in the posterior probability set, was it like just like a few, or it was like?
It's only a few. I don't remember, but it's like less than 10 that are actually. That gives kind of a confidence to say, okay, the whole GWAS is not wrong because we see too much in there, but there is, when we do fine mapping, we only see a few, yeah, as you would expect in the smaller set, yeah.
Yeah, and then I think you had a lot of like EWAS data correlating like cardiometabolic risk factor. And I think she explained that breast cancer, like the density tissue, and you're like most of the genes you're getting, like catenin 3, are linked to like fibro fatty type tissue, cardiovascular type diseases, or like that type of tissue across the body. So are you guys gonna also like investigate that?
Yeah, I think that there's been, so I think in the studies of white women, it's become more common. And I think because it's trying to be similar to the clinical measure, there's been a lot of use of percent density or the amount of dense tissue and kind of almost throwing out the non-dense tissue or the fat tissue. I'm really interested in looking at the interplay between the dense and fat tissue and what's actually going on mechanistically in the breast, because maybe, we see this association with obesity and breast cancer risk in postmenopausal women. It'd be interesting to look, is it really BMI? Is it systemic obesity, or what about fat in the breast? Is it more important that, what's more important for risk of breast cancer? Is it actually the amount of fat tissue in the breast and the inflammation markers that happen between adipose tissue and fibroglandular tissue in the breast? Or is it really about like the global, global amount of fat tissue? So I am really interested in that area, and there really hasn't been a lot of work done in that area to try to figure out if there's more to it in terms of the interaction between the fat tissue and the dense tissue. I think we're definitely seeing some of those cardiovascular signals, and I think that could be super interesting to look into. And we also have some biopsy data. So like all patients have had a breast biopsy at Penn, their tissue has gone into this tissue repository. So we actually have talked with some colleagues about doing more of a mechanistic study looking at, markers in the breast and how that correlates with whether the patient ends up getting diagnosed with cancer or not.
And one last question was just hormonal adjustments. Did you include did you have data actually from PMBB, like with women who are actually on like maybe certain hormonal treatment? Yeah.
Yeah. Well, so we have that, we're pulling that information from that risk factor data that just lives in the radiology website. So we pulled all of that so we can build that in. It wasn't in this analysis, but it's definitely, because we know that hormone replacement therapy is associated with breast cancer risk. So we can look at that. We also we also should include menopause status, obviously, in the final analysis, because we know that there will be a decline in density after the menopause transition.
Is there a question online? I see something in the chat.
Oh, yes.
No?
Yeah, I just asked them if they had a question.
Oh.
so they told me. Yeah.
Okay.
Yes.
Okay. Any other questions? And if not, thank you again. That was really interesting.